Good afternoon. Thank you all for joining us for our 2022 Big Ideas Pitch event. We're so excited to be having you all attend in person. It's been quite an adventure over the last couple of years hosting this virtually. So we're so excited to be offering this as a hybrid event today. A few logistics for today's event. My name is Ali Cazador. I'm the director of the Healthcare Innovation Lab, one of the sponsors for Big Ideas. Our event agenda is that from 2 to 2:10 today, we'll have some opening remarks from Dr. Tom Maddox. From 2:10 to 3:40, we'll do team presentations. And then from 3:40 to 3:50, we'll have our closing remarks from Dr. Philip Payne. For the audience, both virtual and in person, we have audience voting. You'll see in the room here that you have a QR code printed out in front of you. You can feel free to scan that. We are asking that, as well as our virtual teams, we have the link referenced here, that you vote on the 3 categories similar to how our judges today are going to be voting in terms of the clinical applicability, feasibility, and team composition. Please rank them high, medium, and low, and we'll review those results at the end of today's session. Finally, our teams presented here are Team 1, looking at artificial intelligence-based treatment planning workflow for decision-making and proton therapy. Team 2, AlloCold biomarker technology for early prediction of chemotherapy-induced peripheral neuropathy. Team 3, looking at care transition or trust, and trust through understanding via smart use of technology. Team 4, intelligent clinical decision support for perioperative blood management. Team 5, See and Treat, a patient-centered radiation oncology paradigm. Team 6, improving diagnosis of superimposed preeclampsia, a wearable device for non-invasive continuous monitoring of fluid dynamics in pregnancy. Team 7, reduction of blood culture contamination through a data-driven targeted education campaign. Team 8, remote blood pressure monitoring. Team 9, using 3-dimensional movement data and deep learning to predict recovery in cervical myelopathy. And Team 10, evaluation and validation of a mobile application for patient functional assessment in spinal surgery. And here we have Dr. Tom Maddox with our opening remarks.
All right, thank you, Ali. Good afternoon. It is great to finally be in person again after a couple of years of hanging out at home on Zoom. So welcome to the 4th iteration of the Big Ideas Grant Competition. As I said, I'm Tom Maddox. I'm the Vice President of Digital Products and Innovation and a cardiologist at WashU. See, I can just transition easily between the two. We've been running this competition for 4 years. During that time, we've had 21 grants awarded to the tune of over $1.1 million. And there really have been some amazing ideas that have been tested through this program. A couple of examples include machine learning that predicts palliative care needs among our inpatients. Another team used Fitbits to monitor the post-op recovery after abdominal surgery. We have a couple of projects in place right now using digitally enabled incentive spirometers to reduce pulmonary complications after surgery. And we also have a project going on in our ICUs using a wearable patch to monitor pressure on the skin and joints to try and avoid pressure ulcers. So all of these, and certainly the projects today, will also demonstrate really creative ways to use digital technology and information to try and optimize health outcomes for our patients and improve the care experience for our care teams. So I'm looking forward to the 10 presentations today. We have an august panel of judges, and you've got some pictures here. Clay's picture was taken about 2 days ago. But we have Clay Donegan, who many of you know. He's the Senior VP and the Chief Clinical Officer for the BJC Healthcare System. He's also an infectious disease physician in the WashU faculty practice plan. Katie Henderson, an internist, also a VP and Chief Medical Officer here at Barnes Jewish Hospital. Dr. Nicole Mercier, who's the Assistant Vice Chancellor and Managing Director of our Office of Technology Management. Adam Wilcox is a new addition to our institution from Seattle. He's the director of our Center for Applied Clinical Informatics. Dedrick, who's a little MIA, but we'll get him here shortly, is our Vice Chancellor for Operations and Technology Transfer, and now he oversees innovation for the school. Dr. Linda Richards is the Chair of the Department of Neuroscience and the Edison Professor of Neuroscience. Deb Odell, who I also realize is a little MIA, so we'll track her down as well. She's virtual. Thank you. Good to see you, Deb. She's our Chief Data Officer for the system here at BJC. And then finally, John Lynch, who is a pulmonologist and also the president for Barnes Jewish Hospital. So all of them were selected because they have a great collective view of our health system and both the opportunities and some of the challenges that we face in effective care delivery. And as they evaluate these projects, they'll be able to bring that expertise and perspective to say, is this something that can help us achieve our collective mission of better health? So with that, I think we'll get started. Who do I move to next? Team one, you're on. Good luck.
Good afternoon. Do I advance myself? Okay. All right. Happy to be here. Good afternoon. I'm Stephanie Perkins. I'm the director of the Esley Kling Proton Therapy Center and working today with a team of people, including Dr. Sun, who's available virtually, who will answer most of the questions on artificial intelligence-based treatment planning workflow, decision-making, and proton therapy. So for patients with cancer that require radiation, we have the option of treating them with X-ray therapy or proton therapy. But proton therapy has advantages in allowing for better sparing of normal tissues because we can stop the beam of radiation in tissue and spare things such as the heart, lung, and brain. However, this is a limited resource and we're only able to treat a small fraction of our patients with proton therapy. So we must choose which patients are the best for this modality. And currently that process is quite cumbersome, including a review at our triage meetings and the development of both proton therapy and X-ray therapy plans for our physicians to review to decide which patients will derive the most benefit from proton therapy. We believe this process can be streamlined. We are proposing to do this, a change of our current workflow, which is that we take a CT scan on a patient and the physician must manually draw all of the normal structures that are pertinent for that patient, such as the brain, salivary glands, spinal cord. And then those structures are sent to our physicists and dosimetrists to actually complete both a proton and X-ray therapy plan for review. And this can take up to 10 to 12 hours per patient, depending on the complexity. At that point, the physician reviews and makes a decision on which modality. And obviously, this expends our human resource capital and expertise. And we think with an AI approach that this can be streamlined and more efficient. What we're proposing to do in this proposal is to take that CT scan and use a commercial-based product called RadFormation to generate those normal structures automatically, thus saving us time. And then most of the work will be the second flow chart in which our team of experts will take previously treated plans for both X-ray and proton therapy to inform models to give us predictors of what a proton and X-ray therapy plan would look like for a given patient. Thus allowing our physicians to know for each patient what to expect for that dose distribution, saving time for our teams and also giving a personalized recommendation for each patient. This is a multidisciplinary team that spans the Danforth Medical Campus and our leaders at BJC, including our manager, Mike Watts, in the Proton Center. It's a group of physicians, physicists, and computer experts really wanting to leverage our expertise in informatics and clinical care to develop a workflow to help us personalize those recommendations for patients that derive the most benefit for proton therapy. Thanks for your attention.
Yes, first, can you explain once more what the comparison is? This is looking at how the models compare to previous decision making.
Yeah, so the models would be derived to take a given patient with a diagnosis of, whatever diagnosis, and it would model what a proton plan and an X-ray plan would look like. What will the coverage of the target be, which is obviously our number one priority, and what is the sparing of the normal tissues? Does proton therapy lead to significant improvement in sparing compared to X-ray therapy for this patient? So instead of actually doing that manual work for each patient, we would have this model that would inform us of what to expect for a given plan.
Could I ask, how does AIM-1 influence AIM-2? What's the interaction between AIM-1 and 2?
Yeah, is Dr. Sun available to comment from the virtual space? I think he's best to address the specific aims. Baljo, can you speak up? I think you're muted. Or Tanya, if we have another member of the team. I don't think they're listed. Is he talking? Can you tell? Okay. Baljo's son. All right, can you speak, Baljo? Go ahead and unmute yourself.
Okay, now I can. Thank you very much. So the phase one, the AIM-1, AIM-2, they are related. So the first step is based on the contour, and the next step is based on contour, and we make plans. So in the past, we have developed some auto segmentation based on AI. Because this is a one-year project, we like to use some commercial product, actually just released. Probably we're actually in the process of evaluate the right information, and we can use that to speed up our project. We're focused on AIM-2 for auto planning.
Dr. Perkins, a quick question on the connection with this improvement and actually having the proton beam serve more patients or be more efficient. I think I missed that connection.
Yeah, so, obviously another goal of our center is to increase our patient numbers, but as a department that treats, upwards of 400 patients a day across all of our centers, we still have to choose which patients will receive proton therapy. And so that's really, we know for some patients, such as children, they will always receive proton therapy, but for those adult patients, which patients can we use X-ray therapy and it will be quite good to excellent, and which patients and which proton therapy would make a huge difference, rather than doing this 10 to 12 hour evaluation. This would allow us to streamline that, to maybe escalate certain patients down the road for triage, to identify, yes, this is a patient that would really derive significant benefit from our other centers to come here for proton therapy.
Can I add a comment on this question? So this approach, I don't think our goal is to increase capacity to treat more patients with the proton therapy, but based on our prediction, we can decide which patient are best benefits from proton therapy based on the comparison AI-based approach.
So is the difference that you're trying to achieve here based on improvement of workflow, that 10 hours that you've mentioned, or is it actually going to be a better outcome in terms of the selection of the individuals? I'm having trouble figuring that out.
Yeah, I think both. I think currently our workflow is really too cumbersome to do these comparisons for every given patient. And so we kind of rely on a physician experience to say, I think this is going to be better, or I think it's not. So we really want to be able to evaluate more patients through this workflow in a way that's more efficient. And then also just giving that personalized recommendation for a patient. We're recommending proton therapy for you because based on the models, it's going to lead to a significant decreased dose to your normal tissues.
I can also add one comment, not only about speed up the process, also provide a tool. For example, after CT scan, we can immediately show the dose to our patient during our consultation. provide a better way to communicate to our patient, and also provide a tool for like a community hospital. They can use this tool to like referral to patients to proton therapy, because for a certain type of patient, they probably have the best modality using proton therapy to treat cancer patients.
Team 2, thank you so much, team 1.
Hello, everyone. I'm Simon Haratunian, Department of Anesthesiology. Our proposal today is focusing on developing a biomarker technology for early prediction of chemotherapy-induced peripheral neuropathy. So chemotherapy-induced peripheral neuropathy, or CIPN, is a major complication of several cancer drugs, including oxaliplatin, that improve survival in colorectal cancer. CIPN causes pain and burning and forces to stop chemotherapy early or reduce its dose in about 25% of patients. Also, it becomes chronic in about 10 to 20% of patients who receive oxaliplatin, and causes major quality of life impairment. And so current strategies for treating or preventing CIPN have been largely inefficient, including in trials that we have done here. And importantly, there's really no predictive tool to identify patients who are at risk for developing CIPN. And this is our goal in this proposal, to try to identify those high-risk patients, because then we can personalize treatment approaches to try to improve patient safety and improve quality of care. So as clinically, such a biomarker will really improve our ability for clinical decision-making to adjust therapies to improve patient outcomes and prevent neuropathy. But it would also have a major value for research, because then instead of enrolling everyone who receives oxaliplatin in some sort of treatment or prevention trial where everyone is exposed to risk, but only maybe 25% would benefit, you can identify high-risk patients and enroll them specifically in a targeted way and improve trial efficiency and reduce costs. But what would be such a biomarker? And so cold sensitivity with oxaliplatin treatment have been associated with CIPN, but never in the quantitative relationship until now. And this is where our Big Ideas project comes in, because in our preliminary work, we have identified that in patients with colorectal cancer, if we assess daily cold sensitivity in the hands with this custom-made refrigerated metal rod on a daily basis, we can predict CIPN 2 to 4 months before it happens. And so we used a pretty crude approach of pencil paper-based sort of data collection, and it wasn't very efficient. So in our proposal here, we basically, in our first aim, we want to develop a mobile health technology that can allow patients to collect this data in a digital way, to allow data aggregation and future risk prediction. And the second aim, we will test the usability of this technology in a cohort of patients with colorectal cancer undergoing chemotherapy. And we think that this will be really an innovative new biomarker for predicting CIPN. So our collaborative team, beside of me, we're collaborating with Platform STL, which is a local company that has expertise in developing digital health technologies. And they will both help us develop the technology prototype and commercialize the product. And then we have 2 additional collaborators, Joanna Abraham, who is an expert in decision support tool design that's patient-centered, as well as 2 oncologists, Dr. Tan and Peterson, who are experts in colorectal cancer and chemotherapy. Thanks for your attention. Happy to take any questions.
I have a naive question, which is how do you quantify cold sensitivity and account for the differentiation and how people sense that?
Yeah, so it's actually a pretty crude way. We have this pre-refrigerated metal rods that they take it out. Patients held it for 10 seconds and just rates the rate of unpleasantness on a 0 to 10 scale. And we have looked at the area under the curve between each 2 weeks of chemotherapy cycles. And when we quantify the rate of change in that area under the curve of just self-reported cold hypersensitivity, it has specificity of about 83% and sensitivity of 67% of predicting CIPN, just based on quantifying that patient-reported cold sensitivity on a 0 to 10 scale.
In this first go-around, are you simply going to correlate those results with subsequent development of neuropathy, or are you going to actually make treatment decisions based on it?
No, so in this stage, we just want to test the usability of the technology, of the digital technology to collect this data and have the ability to aggregate and perform the risk prediction. We'll need a much larger study for both analytical and clinical validation, probably around 80 patients, and just for that. And after we verify the technology, then it will be a treatment trial. And so it's a 3-stage process for that.
So what's your current number needed to treat here? So as you said, it is 25% have this. And so if you're going to do everyone the cold sensitivity and you've got a 68% sensitivity and the specificity, like what do those numbers look like if you're going to do this broadly in terms of how many people are, how many times do you hand someone a piece of, a piece of cold iron or whatever it is before you find someone that you said, oh, we can prevent this?
So the oxaliplatin treatment in this setting is usually 10 to 12 cycles of 2 weeks. Then patients tend to develop it towards 8 to 12 cycles. It's cumulative. So typically by cycle 4 to 5, we can identify the risk. So our compliance with these methods has been more than 90%. So patients do it daily. It's not a big issue. The problem, if we fix the specificity rate at 75%, because if we say that no one develops it, we would be correct. And any improvement from 25% sensitivity is good. So we think if we can have with fixed sensitivity, if we can have with fixed specificity more than 50% sensitivity, it would be a good outcome, ideally in the 70th range. With 50% sensitivity, we'll probably cut the cost by half in terms of just study size or sample size that you will need to include in trials.
Any other questions from our judges? Thank you, team
All right,
2.
thanks a lot.
All right, well, thanks for the opportunity to pitch our proposal, Care Transition Trust. Our team believes our proposal aligns well with BJC priorities, especially safety and quality. And our project focuses on hospital discharge transitions, an important issue, I think, as BJH attempts to lower its readmission rates. Now, extensive research documents quite well that patients and their family caregivers lack trust in their hospital care team. Personally, I came to this recognition when a geriatrician performing home visits called and told me that patients I had discharged from the hospital did not fill their prescriptions and were not stopping medications that I had directed them to do that. So why not, I wondered. Well, she asked them and they told her, I trust my primary care doctor. I don't trust the doctor in the hospital. I need to talk to my primary care doctor who I trust. Oops, I think it's advanced. So Project Achieve is a project that linked Medicare data to 8,000 patients surveyed as they went through the hospital discharge process at 42 hospitals across the US. We found in that study that patients who trusted their hospital care teams had associated better patient-reported outcomes. They had improved patient experience scores and actually reduced 30-day readmissions and 7-day visits. So it's kind of fascinating when you look at the technology around this. We wanted to implement an innovative handshake between hospitalists and PCP using bedside communication with an iPad. Now, this is relatively new technology. We may not realize this. The iPad came out in 2010, FaceTime in 2011, and Zoom in 2012. So we want to conduct this project looking at outcomes, particularly hard outcomes such as subsequent ED visits and readmissions, as well as self-efficacy of the patients and their satisfaction. But I want to actually demo this. I have some of our team members who took a little time to show how this works.
Hello, Dr. Voss. I have your patient, Mr. Jones. I'm discharging him from the hospital, and I'd want to let you talk to him.
Thanks, Dr. Reuter.
Hi.
Hello, Mr. Jones. It's so good to see you. I'm glad you're doing better and ready to go home. I've talked with Dr. Reuter about your care at the hospital. He's an excellent doctor and done a great job adjusting your medications. Please fill the prescription for that new blood pressure pill he suggested. I look forward to seeing you next week in the office. What questions do you have for me?
So these are our collaborators, and I think they understand something that the hospital discharge process has been. And in a way, it's kind of like the football Hail Mary pass. We toss the patient out of the hospital. We hope someone is there to catch them or the system will catch them. And I think this occurs too often. And I think this technology application can help. These are our collaborators. It's a mix of primary care providers, hospitalists, and researchers.
What's the feedback that you've gotten from primary care providers about how they would fit this into their day?
So you raise a very important issue. And so we talked to them in advance. We've talked to the primary care group here at BJH, as well as out at MOBAP. And you saw the MOBAP hospitalists and Dr. Voss out at MOBAP. They think, and part of this is that this will be a brief interaction. This will not be a long interaction. And that with it being brief, and this fits with my experience as a hospitalist calling primary care providers, you can usually coordinate 5-minute interactions. What this does especially is it confirms to the patient that the primary care provider knows about them being hospitalized, and that the primary care provider knows the hospitalist, trusts them, and can confirm that the patient needs to follow that advice. Ideally, if we demonstrate this to work, I'd like this to become a health policy issue, that we show this to CMS and use these discharge care transition billing codes or other codes so that PCPs get paid for this. In Colorado, there are private insurers that are actually paying primary care providers to get involved in the hospital process, not to take care of the patients in the hospital, but just simply to interact with the patients. And so they're getting payment for this. So this is not completely novel. It would be novel for CMS, but I think it has future promise.
We do have a question from our virtual judge, Deb Odell. Deb, can you come off mute?
I'm curious what the scope of this is for you to start. I mean, is it at certain facilities, certain types of diagnoses? Where do you want to start?
Yeah, so we're going to do this at 2 facilities, at Barnes Jewish Hospital and at Missouri Baptist Hospitals are our 2 targets, with the hospitalists and then the local primary care physician groups there. So patients will be identified based on whether or not they're taken care of by one of these local primary care groups. And then the hospitalists will be informed and then reach out to the primary care providers accordingly. Haven't decided on which iPad. I tried the iPad mini. It's kind of a little bit small. This was actually a very large iPad. Probably know it was something in between.
But is it every patient, or will you narrow the population?
No, it would be every hospitalized patient. And I think we'll
Okay.
obviously assess to whether or not they have significant cognitive impairment as we do this. But if there are family members available, I would want to do this with them because they're going to be the individuals taking care of those patients. And we'll have a structured sampling approach in our analysis.
Thank you.
So I really like this idea, but as I'm listening to it, I'm wondering if how much of the process of getting all of this set up, that the patient has a primary care physician that knows that they are their patient and is linking up, how much of that is already filtering to the people who are probably going to have better outcomes at care transitions from the hospital anyway? And how are you going to adjust for that or account for that?
Okay, so we'll be able to, I think, pull a lot of that data from Epic. I think you are right that if somebody has a primary care provider, that usually triggers the fact that they're going to have a better outcome. Interestingly, this large study was an association study, so we don't know for sure. And this was one of the reviewers' concerns. But there's a vast literature now that's showing over and over again, if patients trust their providers, their outcomes improve. And I think there are good theoretical models that make sense for this. And I think we're going to get a mix of those types of patients here at BJH. At MOBAP, I think it's a slightly different patient group. But again, I think when these patients that I was discharging was actually from a very well-to-do hospital, if you will. I think John Lynch would love these figures of uninsured of 2% and Medicaid single digit, also in commercial over 50%. We had a sort of different intervention where we had PCPs calling the patients in their room, and we saw the needle move with that. And so I think this is a way to do that.
Sorry, just following up on Katie's question. So is this a random call, or are you going to set up appointments for the two providers to rendezvous?
Correct. Yeah, basically, we are going to develop an Epic feed. I've actually talked to Jeff Sislo about this, so we know, so the primary care providers know their patients are in the hospital. And usually, and I know there's an attempt to have the primary care providers listed in Epic, and then the hospitals will begin reaching out to them if this is somebody in the group, and then try and set up this, if you will, visitor meeting. I think it'll replace a phone call that honestly the hospital should be having anyway. So yes.
Oh, I'm so sorry. We're out of time.
Okay.
Our next team. Thank you so much,
Sure.
team 3.
Okay. Hi, everyone. I'm Sunny Liu. I'm a cardiac anesthesiologist at working here in the Department of Anesthesiology. And I'm going to tell you about a project that we're working on today for intelligent clinical decision support for perioperative blood management. So bleeding can happen during surgery, and during those situations, it can be life-saving to be able to give blood in a timely fashion. However, the process of actually getting a unit of blood that's safe to administer to the patient can sometimes take hours. So you really don't want to wait until the patient's already bleeding for you to start that process. What we do instead is that typically for patients that we think are at high risk of needing blood during surgery, we will do some or all of the preparation in the preoperative setting so that the blood is basically ready to go when it's needed during surgery. The problem is we're probably overdoing this preoperative preparation. So at Barnes-Jewish Hospital, for example, 60% of patients have preoperative blood orders prepared, even though only 7% need blood during surgery. And this excess ordering probably costs the US healthcare system on the order of $10 billion a year, and Barnes-Jewish Hospital in particular on the order of hundreds of thousands of dollars a year. So why are we so inefficient? The current standard of care for how we make these decisions is to use something called an MS-BOSS, which is basically a chart that says, based on the planned procedure that the patient's having, this is what we typically order for these patients. But you'll notice from this chart that it doesn't take into account any patient-specific factors, like, for example, if they have low blood counts, even though we know that these patient-specific factors obviously impact their risk for needing blood during surgery. So our idea is to replace this chart with a personalized model that uses both patient and procedure-specific factors to make a risk prediction, a better risk prediction of the chance that that patient will need blood during surgery, and to use that better risk prediction to guide the orders that we'll place in the preoperative setting. And we have preliminary data that we've already trained this model. We have preliminary data to suggest that it can reduce the number of excess orders by at least a third while maintaining patient safety. So we're seeking funding to move this idea through to implementation. What we have currently is just a model that exists outside of the electronic health record, and we want to bring it to the point of care for clinicians to use so that it can be useful. So one step of that will be packaging our model as a clinical decision support tool, meaning designing a user interface that's trustworthy and easy to use. And the second part of that will be integrating our clinical decision support tool inside the electronic health record so that clinicians can access it, and validating the model in the setting that it'll be used, which we anticipate to be our preoperative assessment clinic, where these decisions are usually made. We hope to show that our model and our clinical decision support tool is safe and more efficient than the current standard of care. So we've assembled a multidisciplinary team for this project, including Thomas Kanampalil and Joanna Abraham, who are both experts in user-centered design. And then we also have Dr. Hall, who's here today. Thank you, Dr. Hall. And Stephen Gregory, the medical director for our preoperative assessment clinic, helping out with the clinical aspects. We think our personalized surgical risk transfusion risk prediction tool has the potential to really transform our clinical decision-making process for preoperative blood orders, with benefits for patient safety and for the cost of care and for blood conservation. And we're happy to take questions about it. Thanks.
The idea makes great sense. What's the bailout plan for the unexpected case where you need blood in a patient who you aren't predicted to have.
Yeah, exactly. So that's something that we wanted to be really thoughtful about when we tuned our model, because you can essentially tune your model to have arbitrary levels of sensitivity. And we agree that it is clinically really important for your model to be really, really sensitive, meaning it misses very few people that end up needing blood during surgery. So we tuned our model specifically to have 96% sensitivity so that we miss at most 4% of patients who would need blood during surgery, meaning we wouldn't have prepared anything for them. And the bailout plan in that situation would be emergency release blood. So that's something that we routinely do for a lot of patients anyway. It's actually generally thought to be relatively safe. And we have all the infrastructure set up to give it, and we have adequate quantities of blood.
We do have an online question. What's the overall cost of excessive T and C without antibodies over, T and S, without antibodies over T and S?
Sorry, what's the cost of the type and screen itself?
Yes.
Okay, so yeah, so that is a question I've been trying to get the answer to in various ways. So it's probably on the order of $100, I want to say. So I'll say that the Barnes-Jewish Hospital list price for a type and screen is about $490. Medicare reimburses $12 for it. So the true cost in terms of the labor and the reagents and all the people collecting the blood in tubes and transporting it around and running it on machines is probably somewhere in between. Where in between, from estimates that I've seen from other people in the literature, probably on the order of $100. But again, just kind of hypothesizing there. But that is how we're deriving the estimate of $10 billion using numbers like that.
It's a little dangerous for the interns in the room to be asking questions about what goes on in the OR. I'm going to channel my inner Bruce Hall. It seems like what I've heard is that one of the core issues is distrust of the supply chain and the ability for the lab services to provide the blood in a timely way. Will you track the physician adoption, or we have tools that look at how the physicians change their mind about supply chain availability based on this risk score?
Yeah, that's an excellent question. So this project is probably not at the phase that we're going to implement it, although the goal is ultimately to implement it. And of course, when we do implement it, we want to evaluate how much the clinicians use the tool. First, just do they use the tool? Second, do they listen to the tool? And third, what outcomes does it have for patients? But before we get there, I think this is kind of the middle phase. So right now, all we've done so far is just trained a model. The purpose of this proposal would be to build that model into a clinical decision support system and make sure it's safe. It would be safe. And then the third phase, which we hope we can eventually get to, is to actually deploy it in clinics, have people use it, hopefully use it a lot, and measure the outcomes from that.
What's the, go ahead.
I was going to say, presumably you'll have clinicians testing how easy it is to use it.
Yes.
And providing feedback along the way.
Yes, exactly. Sorry, I kind of skimmed over that quickly, but the first aim will be to do user-centered design. So that'll include interviews with key stakeholders for needs analysis. What do they want to see in the tool? How would they like to use such a tool? Make sure we got the right workflow for where would it show up for them. Then we do some iterative prototyping, like we kind of mock up what this tool might look like, have them try it out, give us their feedback, and then do a user evaluation study in the end to make sure we can measure the usability, the impact on their workflow, how long it takes them to use it, just to make sure everything would go smoothly if we were to deploy it.
What's the barrier for change for the clinicians to go from ordering blood to trusting this? And how are you going to adapt your tool for that?
Yes, so I think it's really important to have stakeholder buy-in. I think part of the purpose of building the user-centered design process is to make sure we take into account everybody's opinions and concerns about our product, so that eventually when we do finalize it, that everyone feels reasonably happy with the choices that it's made. I will point out that our current standard of care is to use this chart, and it's not that big of a jump to go from a chart to a different kind of chart. Both charts tell you what to do. It's just our chart is a little bit more complicated and smarter, we think, than the chart that clinicians are currently using. And I will say also that the target user is the nurse practitioner in our preoperative assessment clinic, and there will still be physician oversight. Like the day of surgery, anesthesiologists can still make their own clinical decisions based on what they interpret of the patient. So I think there's an additional level of safety there.
Thank you, Team 4.
Thank you.
Chris. Oops. Good afternoon. My name is Tianyu Zhao. I'm associate professor of radiation oncology. Today, I'm privileged to present our study, the See and Treat, a patient-centered radiation oncology paradigm, because I believe this is going to shape the future of radiotherapy. So the radiotherapy is involved in 50% of the cancer patients' care. So a patient consent to radiotherapy will after weeks of the diagnostic workup, we go to a process called simulation. That's a process that do a CT scan of the patient immobilized for the subsequent tasks like the tumor segmentation, treatment planning, and the delivery. And in our current workflow, the three oncologist doesn't really know, what's the outcome from the treatment plan. So this is the empirical driven process is not aligned very well with the BJC and the WashU's vision to promote for the clinical efficiency and efficacy, and also the multiple disciplinary team approach for cancer treatment with backed by the evidence. So the average wait time for radiotherapy is 25 days at BJC. That's data for 4 years. And the delay of the radiotherapy can cause longer inpatient stays for those who are in grave pains. And also data show that the disease progress is going to get worse with the delay of the radiotherapy. Like for breast cancer, for every week of delay, that's cause 3% of increase in the local failure. And for the lung cancer, I think 1/3 of patients will see the upstage of disease at treatment after 4 weeks of waiting. That's a standard. That's a common in radiotherapy. So this our solution is we propose to do automated treatment planning directly on the diagnostic images. So by eliminating the simulation and move the treatment planning ahead of the consultation. So we were able to, reduce the 4 weeks of wait to 1 day. So just like growing a tree, so this is our new paradigm, just like a tree. Its roots in the diagnostic images is nourished by advanced technology like machine learning, auto planning, and auto segmentation. The feasibility study and the development of supporting technology and the clinical decision enhancement are 3 branches that we're going to develop. And the fruit growing out of the branches are the innovation that's going to shape the future radiotherapy, including the new workflow, the clinical decision work, and also the immobilization strategies for radiotherapy. So we do have a very diverse team from different divisions, different departments. We have people from radiation oncology physicists, from radiation oncologists. We will have engineers, and also from BJC, our partners, who's already working on these awesome projects. So too fast. I will try to push it to the end. Oh, I'm happy to take the question.
Maybe you could just explain a little bit more about the decision, like what is?
Yeah, so for current, the radiotherapy workflow takes like four weeks something at BGSC. So my proposal is we can get rid of some of the bottleneck in the workflow, and by using the machine learning, auto planning, and auto segmentation tools, and then we can reduce the whole time to like from 4 weeks to 1 day. So then we can have a patient give the patient the treatment soon.
What are you training the algorithm on? You're developing an algorithm for diagnostic
Yes, we
purposes, right?
developed.
So what are you training it on? I'm not understanding that.
Yeah, we are trying to use all this the machine learning algorithms. So for instance, I have already did some preliminary study. So I use machine learning algorithm we call knowledge-based planning. So one dosimetrist can finish a plan in 25, even 30 patients plan just in 1 day. So this is like automated process. So that will drastically reduce the planning time, save a lot of cost for the hospital, and just accelerate the whole workflow. Yeah, just we can reduce so we do not have to go through the rest of the workflow. That takes about after consultation, that takes about 2 weeks to schedule for simulation. And after simulation, it takes about 2 weeks to finish the rest of the workflow. By using this workflow, the new paradigm, so we're able to move the treatment planning, even ahead of the patient initial radon consultation. So that will basically we're going to cut 4 weeks waiting time for the patient to 1 day.
So if I'm understanding this correctly, essentially you're using the diagnostic imaging that the patients already had done to do the simulation rather
that's
than
correct.
taking separate simulation. Have you run into issues where the diagnostic imaging is not going to be feasible for your modeling?
So we have to test this workflow for our palliative patients. So far it looks very good. And also we one of the innovation of this for this study is we're going to have new mobilization strategies. So we're going to use the the VR, the virtual reality, using the optical cameras to just monitor set up this patient to make sure this patient setup is correct.
Great. Thank you,
Thank you.
for your presentation. Next up, team 6.
Okay. One more. Okay, hi everyone. My name is Valine Garberry. The title of our talk is Improving the Diagnosis of Superimposed Preeclampsia, a wearable device for non-invasive continuous monitoring of fluid dynamics in pregnancy. So preeclampsia is a common condition. It's characterized by hypertension and end organ damage in pregnancy. When patients who already have chronic hypertension develop preeclampsia, it's called superimposed preeclampsia. Compared to hypertension alone, superimposed preeclampsia is associated with increased risk for morbidity and mortality for the mother and the child, as well as longer and more expensive labor and delivery hospitalizations and increased risk for postpartum readmissions. These outcomes pose challenges for our healthcare system because 13% of our pregnant patients have chronic hypertension, which is 6 times higher than the national rate, and 43% of them develop preeclampsia. The outcomes for superimposed preeclampsia are often challenging and more severe because it's difficult to diagnose preeclampsia in patients who already have hypertension. Although the two conditions are drastically different, they have different management strategies and outcomes, the diagnostic criteria for preeclampsia may be present in both hypertension and protein in the urine. However, only preeclampsia is associated with abnormal fluid dynamics that can be non-invasively monitored using bioimpedance. Therefore, our big idea is to use a wearable device to continuously monitor fluid dynamics in patients with chronic hypertension to identify preeclampsia onset and to promote earlier diagnosis. We propose to first identify and validate the fluid profile that corresponds to preeclampsia in 80 Black pregnant patients with chronic hypertension, as they have the highest risk for preeclampsia. Second, we're going to compare the diagnostic value of the fluid profile to the standards of care, blood pressure and proteinuria. And third, examine patients' perspectives and adherence to our solution. Hence, we propose an innovative strategy that uses the smartphone-based wearable device to monitor fluid dynamics in these patients to improve the way we diagnose superimposed preeclampsia, and in turn, improve our patient care and outcomes for these patients in our hospital system. So we have a fantastic interdisciplinary team that's committed to the success of this project. Collectively, we have expertise in the diagnosis and treatment of hypertensive disorders of pregnancy, bioimpedance analysis and modeling, fluid and nutrient metabolism in pregnancy, continuous data analysis, and wearable devices in pregnancy. Ultimately, we're committed to this project and to improving the way we diagnose superimposed preeclampsia. Thank you. Questions? No questions.
I've got a question. On your slide back, you were looking at comparing your fluid profile to the standard of care. So let me make sure I understand what you got there. You've got basically, 3 criteria. One is a differential. How are you, what are you comparing in the standard of care to your fluid profile?
Yeah, so this one was really difficult to think about. So essentially what we're going to do is look at the changes, right? So we're going to monitor them from the late second trimester into the third trimester, and we're going to integrate all of that data. So they'll have a variable that shows their weekly minimum and maximum values for extracellular water is actually what we're measuring. And we're going to look at the changes in extracellular water, the percent change essentially. And so we're going to compare whatever that threshold is that indicates preeclampsia in the fluid profile to changes in blood pressure and changes in proteinuria. We can't use the diagnostic criteria as it like standard is, because that's how they'll be diagnosed in the clinic. So we're going to look at changes in blood pressure. Essentially, we think that based on the literature, the changes in diastolic blood pressure and systolic blood pressure are minimal over time. And so they won't have as much of an indication as what we see with fluid profiles, which is up to 25 to 30%. So we expect that that will happen before we detect blood pressure changes. And that's what we'll be comparing it to. Is that clear?
It's very clear. Just to follow up, if I may, on the other end, you're looking at wearables and adherence to the actually wearing the device.
Yeah.
Are you also filtering for aversion to wearables and reasons why people may or may not wear them?
Yeah, so we're going to look at the people who join the study because they're going to be asked to, and this is the wearable, they're going to be asked to wear it for 50 to 70% of their days. And so we'll look at reasons why they do not join the study. We'll also look at, when we interview them, we'll ask them what was their experience with the device. Did they feel like it was feasible? We'll look at how much they wear it, and does that tell us whether or not they want to do it? Yes.
Does the data from the wearable go to a mobile phone app, or is it transmitted directly to?
So it's a smartphone based device. So it's Bluetooth to a mobile app. And so for the study, they'll have a blinded app, so they can't see some of the data that we're going to be using, but it is Bluetooth to a smartphone. Yes.
So that you'll use their own smartphone for
Yes,
that?
they'll use their own smartphone. The data can be stored in the device for up to 30 days. So if something happens and they can't sync it or they choose not to, we can sync it when they come in for prenatal care. Yes.
For the device and the system you're using, are there other use cases out there that have validated the ability to detect these fluid shifts?
Yes.
Heart failure, renal failure?
So bioimpedance technology itself is well used for fluid dynamics in all of those cases: kidney disease, cardiovascular disease. This particular device is not validated for that. It is validated to monitor hydration and to monitor essentially overhydration. What we're going to do is actually work with the research development team to get the raw data and to estimate fluid dynamics. So it's not validated for this particular use yet. We're going to actually be doing that. That's one of the aims that we'll pursue.
Great, thank you, Team 6.
I'm Mark Zeidman, and I'm going to tell you about our big idea today, which is reduction of blood culture contamination through a data-driven, targeted educational campaign. Blood culture contamination occurs when harmless bacteria from patient's skin gets introduced into the culture during collection. As a result of this contamination event, that patient is likely to receive 3 additional days of unnecessary and potentially harmful antibiotics, to spend 5 additional days in the hospital, and to spend an additional $9,000 on their hospitalization. Meanwhile, the micro lab is working up and spending resources on a false positive. The hospital is incurring financial losses, and the public is harmed as IV antibiotic usage drives drug resistance. Unfortunately, contamination is very frequent in our system. Every year, the BJH microlab receives over 3,000 contaminated cultures. In fact, over 30% of all positive blood cultures are falsely positive due to contamination. So the literature tells us that providing additional education to collectors on proper aseptic technique is very effective at reducing contamination rates. However, educational intervention is expensive and it's difficult to scale to such a large and complex healthcare system as we work in. So our big idea is that we don't have to direct these additional educational interventions to everyone. We can use clinical data to target our intervention towards those collectors that need it most. By investing in our big idea, you will enable us to create an informatics pipeline to identify significantly outlying collectors in our system, both under and over performers. We will figure out what distinguishes these two groups of collectors, and then we will use these insights in our pipeline to deliver targeted education to those who could benefit the most. This will provide a sustainable, effective, and scalable strategy for addressing blood culture contamination. To accomplish this project, we have assembled a team of diverse expertise spanning informatics, microbiology, infection prevention, and quality management. These experts are representing Washington University, Barnes Jewish Healthcare, and Barnes Jewish Hospital and BJC Healthcare. By working together, we are going to reduce blood culture contamination to improve patient outcomes and optimize hospitalization system-wide. Thank you for your attention, and I welcome your questions.
Do you have any preliminary data that culture contamination clusters in individual operators versus just being randomly distributed?
So yes, so we've looked retrospectively at our data, and what we've discovered is very interesting. So first of all, most of our collectors are doing pretty well and are performing comparably to each other with random month-to-month variation. However, with a proper statistical model that takes into consideration the volume of cultures collected, the contamination rate for that individual, as well as that individual's peers, we can identify the significant outliers. Some of what we see in the data is no surprise to us. We have particular clusters, for example, our ED locations are typically running higher rates of contamination than inpatient locations. So yes, now as far as clusters where we might gain more insights as to what are the features, for example, that define these clusters? Is there something different about this practice setting? Were these individuals exposed to some education previously that can explain their under or over performance? Those are things we hope to learn within our project.
Can you talk about how you are going to deliver it to the target? So I'm thinking an individual's psyche, you know, when they're communicated that they're an underperformer.
Yes.
Can you just talk about how you're going to deliver that?
Yeah, so that's an excellent question. The question was how will we deliver our intervention and also considering the human on the other side and the potentially negative impact of receiving that feedback. So physically, how we will deliver, we have a number of different interventions ranging from digital-based training modules that can be delivered to their online training portals to trained educators that can be deployed to provide on-site training. Now that's kind of the physical question, but your question is more related. So we're coming at this first with the position that blood culture collection is difficult. So to collect that blood, a needle has to go through skin, and skin is covered in bacteria. Also, we are all doing our best for the patient. And so the idea here is to provide the necessary tools and education in a way that is not punitive and that is not demoralizing to the recipient and is not judgmental. And so to do that, really, I think the key is soliciting input from nursing management. We have several folks on our team who are of nursing background to help us design those interventions. But ultimately, we do believe that the blood culture collectors and the nursing staff here want what is best for the patient, and will ultimately see that we are working together to achieve that goal. This is
Hi.
Dr. Yarbrough.
I'm the medical director of the micro lab here. I'll just add that currently the vast majority of the 100,000 blood cultures performed in our lab each year are obtained by PPID. So we're already manually compiling a list and sending that out monthly, but it's usually pretty late. It's manual, as I stated, and then that list is going out to individual units for individual feedback. So the feedback's already going on. It's just that there's no data back behind it to state you truly are an outlier. It's a feeling of sort of the person reviewing the list. So I think in many ways, this is going to become even more objective rather than subjective, backed by data. And then we also want to target those people who are doing better than all the others too. So we're hoping that there will be also not just punitive effects, but also effects of really understanding, wow, I'm doing really good. And how can I utilize those skills to help people around me in my units?
And I don't know that this is a question so much as a comment, but there's the feedback to the individuals about how they personally collected the specimen, but some of this, especially if you're seeing clusters in certain areas or patient types, may be around the initial education that they got. And we do that better with some groups than others. So hopefully some of the feedback will also go to those who are educating the folks in the first place too.
So our pipeline will cover, will aggregate statistics and identify outliers at the level of collectors, locations, and institutions as well.
Thank you. We are out of time. Thank you, Team 7. Good afternoon. My name is Jenny Schmidt. I'm a general internist here at WashU, and I'm going to talk with you about our big idea on remote blood pressure monitoring. I feel like we should have had a lot more words in this title, so I'm feeling a little bit nervous about that. So what problem are we trying to solve? Hypertension is the most common health condition in the United States. It affects over 30% of the population, which is over 63 million people. And of those 63 million people, more than 50% of them have uncontrolled high blood pressure. As you can see from this graphic in the lower, your left-hand corner, St. Louis is no exception. That shows hypertension prevalence by zip code here. Uncontrolled hypertension leads to a variety of complications, including heart attacks, heart failure, strokes, vision loss, kidney disease, and death. And in fact, hypertension-related deaths have increased 23% in the last decade. Within our clinics, a hypertension diagnosis can lead to low quality of care scores, poor health team utilization, and unavoidable ED visits. So why now? As a result of the COVID-19 pandemic, virtual care has exploded, yielding rapid patient adoption and high patient satisfaction. Previous care barriers, such as lack of transportation, have been overcome, as many patients are able to access their healthcare team through a smartphone. As of February 2021, 85% of Americans own a smartphone. Intervisit programs that integrate into the EHR result in better healthcare team utilization, allowing multiple care team members to manage patients' needs. And as we continue to deal with staff shortages and an increased demand for work from home positions, virtual care programs redirect time for practitioners to focus on more complex issues, allowing clinic staff to work to the highest level of their license and create more remote roles to expand our workforce. Our project leveraged technology to automate blood pressure readings directly into Epic. Epic then triages these readings based on a built-in protocol, which you can see here. And clinic team members can reach out to patients when alerted by an abnormal result, adjusting their medications via phone, or setting them up for a visit as necessary. The staff can also provide lifestyle management tips and answer any questions that arise. Our ultimate goal is to achieve improved blood pressure control in our participating patients, as well as increase patients and healthcare team satisfaction. Not only is this product usable in hypertension management, but it's really scalable to multiple other
diseases such as diabetes with glucose monitoring, and it can be used across different types of clinics. You can see here our collaborative team. We have physicians, we have a hypertension expert, pharmacists, practice administrators, nurses. We have people who are at BJC as well as WashU, those who are seeing patients in the accountable care organizations, as well as more traditional primary care clinics. So it really is able to reach a number of patients, and everybody is a primary care doctor. Thank you.
Dr. Schmidt, I have a quick question about actually how you take the readings and how do they end up in the system that then triggers all these interventions?
More. So there's a number of Bluetooth enabled blood pressure devices that are already sold commercially for less than $100 that come pre-integrated with the app either through Google or Apple that flow into Epic. So it's pre-built and it's already inside of our Epic instance. We would have to specify the algorithm, but the hard IT part is already.
And I guess with the IT part of this too, so whatever app you're using, we know, you know for sure already that this does integrate with Epic and that there aren't IT security issues that are going to come with that.
The Epic build is done. It's really more about operationalizing it from the app into the clinic space.
So there's been remote blood pressure monitoring for years, and I'm just trying to figure out which of the following you think is the biggest difference that this is making. Is it the integration with IT that's been mentioned already? Is it that this is these devices are cheaper and that you can distribute them more easily? Or is it, as you mentioned, something about this time period post-COVID? Well, hopefully post-COVID, but this time period that we're going through now, that it's a different urgency around measuring that. Which of those things do you think are you seeing as the most important aspect of this intervention?
Yes. Like I said, remote monitoring use the mic.
Here you go.
Sorry, remote monitoring's been around for a while. Is, we get patients who just mail in a list of their blood pressure readings. That's remote monitoring, but now it's built into Epic, which is huge. And we build the clinical workflow around it through video visits, telephone visits, pharmacists, so that it can be addressed rather than just saying, follow up in 3 months. Like we can address these in between and use our technology to monitor adherence and direct resources to the patients who need it at the right time.
There's also been such a huge change in the actual adoption of using virtual health from patients. So I know my grandma, who's 88, would never have thought about doing a virtual visit before, and now does them all the time, no problem. And so now seems like a really opportune moment to seize on that and do what we can to improve our patients' outcomes using it.
The other thing that I'll mention is that we're measured as a system on our control of patients with hypertension. We perform poorly. So there are direct financial and quality metrics already in place that could be improved with this sort of program.
So it seems like the challenge here is less the technology and more the support services afterwards. So how does that play into your solution development?
So that's what we want to build, is we have that technology piece. So how do we take that it sticks this data into Epic, and how do we utilize that on a regular basis using our healthcare team? So one of the other huge problems that's come from COVID is the massive increase in physician digital work. So the number of MyChart messages that physicians are getting and managing more and more. So this really allows the physicians and advanced practice providers to be offloaded and to allow the other clinical staff to really work at the highest level of their license, to utilize our nurses and our MAs to help manage those patients.
There's some other health systems with remote monitoring programs where the pharmacists do all the work. Yep. They order the meds, they order the labs, they call. Physicians never see the patients. So we think that's probably a step too far, but we want to build a hybrid model that goes within the system that we have.
We do have one question online, and this is in context to maybe some of the technology and the training that would take place. Wouldn't it be best to deliver the best training information to all? This can be easily accomplished with existing digital platforms.
Training on what?
I'm not sure what that means.
Yeah, no, this came in at 3:02. We'll get back to you, questionnaire. It's anonymous. Thank you.
Thank you.
It's 9 time. Great. All right, well, good afternoon, everyone, and thank you for the opportunity to present our big idea. I'll move a little bit closer to things. Our big idea using three-dimensional movement and deep learning to predict outcomes in patients with cervical myelopathy. So the problem with cervical myelopathy is compression of the cervical spine that typically has patients over time develop loss of dexterity in their hands, difficulty walking, gait disturbances that frequently results in falls. Classically, cervical myelopathy presents in patients over the age of 40, and typically these patients are in the prime of their working careers. And as a disease process, it can really disrupt their ability to work and provide for themselves. So how is it typically diagnosed? It's usually a provider like myself. I'm a neurosurgeon in the Department of Neurological Surgery with a subspecialty in spine, in which we look at, using various metrics, how a patient performs on examination and various other ordinal scales based on surveys. The problem is that a lot of this is very subjective. It's based on a provider like myself having an assessment based on my clinical expertise, whether a person's moderate, severe, mild on initial presentation. The thing is, we do have very distinct tools to measure outcomes in movement, and we know that there are various performers in terms of how well they move based on these more objective metrics. And so what we're postulating, and this is a system that we've already started to develop, hopefully this video plays, there we go, where we have a patient here who's providing a simple clinical task, which is called heel-to-toe tandem gait walking. And using three-dimensional cameras, we're able to actually quantitate how variable they are versus a normal control patient. And we can actually assign a number to that. And using that, and after doing some pre-processing, actually classify not only clusters of who have severe myelopathy based on the performance on these tasks, but also predict their recovery after a surgical intervention. And then I have future directions in which we can actually train a collaborative robot based on how they perform after surgery on these various tests. This is a collaboration between myself, Mayo, who is one of the assistant professors with a joint appointment in biomedical engineering and neurosurgery, Sandra McCormick, and Dr. Phil Payne, who will all allow us to not only integrate what we are able to obtain objectively using our 3D motion capture, but also integrate it with the electronic health medical record to better do some prediction on these patients. Thank you.
Can you explain more what you mean by the integration with the electronic medical record that you mentioned just at the end there?
That's great. So the good thing is I spent the least amount of time talking about that on purpose. So, so there are various features that are very predictive of how likely a patient is to recover from spinal surgery. Their BMI, their baseline functional status, their age, whether they work or not. Right? These are independent predictive factors. These are things that you can easily pull out of Epic. Usually now we have a human who does it, but these are something that you can, pull, from Epic based on who, someone who puts it in. So we know that those various factors are already predictive of outcome, but, them in and of themselves, if a patient comes to me and has a BMI of 45 and I say, well, based on that one factor, you're a low likelihood of improving with cervical intervention, they'd be pretty unsatisfied. But if I can have them do a number of tests and based on their performance of that test, be like, well, this is likely why you're going to perform poorly after surgery. I think that generally has a little bit more of I guess, political correctness.
Can I ask,
Yeah.
is there a commercial software that you're using for the 3D motion capture?
Yes. So actually it's not a it's a research software that's typically used not only in mainly orthopedic, assessment of joint movements, but also in post-stroke patients. Those are the patients who it's been classically used with. Mayo actually has an expertise in patients who have had strokes. We're just extrapolating the use of that 3D motion capture to cervical myelopathy.
So I have another question. Sorry about this, but it was stemmed from the answer you gave for the previous one. So you kind of indicated that there are cases where you kind of know the answer beforehand, but it can be helpful in giving the answer. And I was wondering as I was watching this, are the experts able to? Does the software provide much more to the experts that they can't already tell? Is it a situation where they know it when they see it, or does the data really kind of inform them of something they wouldn't have realized otherwise? And what percentage is that happening?
Great question. So I have this mantra: if you show a spine case to 10 different spine surgeons, you'll get 15 different answers, right? So one of the reasons for that is there are very different, there are early responders, there are delayed responders, and there are non-responders in terms of spine surgery, right? There are patients you do a surgery on, and immediately after they're like, oh my God, I can move my hands, I can button my shirt, I can walk like a mile. And we, truthfully, as surgeons, we have no idea who's gonna be delayed, early, we don't know. As a surrogate, we know time from diagnosis to surgery is a surrogate for being a non-responder. We know that, but we don't know necessarily the clusters, right? Are you a person who's gonna respond with immediately after surgery, 6 weeks after surgery, 3 months after surgery? That gives us a little bit more information of how to cluster these patients.
Great. Any other questions? Oh, Dedrick.
Yeah, good question. So when you speak about predict recovery after surgery, this is both time and level of functionality someone regains?
Correct.
And the severity score, is that something that is manually available now? You're just going to be assigning this?
There are as many people in this room, there are scoring systems for cervical myelopathy. Probably the most commonly used amongst American spine surgeons is the MJOA, the Modified Japanese Orthopedic Association scoring system, which basically arbitrarily says, do you have difficulty buttoning your shirts? When you walk upstairs, do you use a handrail, right? These are very ordinal metrics, right? And truly function is a continuum, right? There are people who, irrespective of whether they need to use a handrail or not, when they walk upstairs, they say, I have poor function, right? And so this project is really about assessing and really assigning a number to that continuum so that we're not using these kind of more ordinal metrics.
Thank you so much.
Thank you.
And for our last team, Team 10.
So good afternoon. My name is Camilo Molina. I'm an assistant professor of neurosurgery and orthopedic surgery here at WashU. I'm quite close here with Dr. Penny Cook, and I didn't quite get to see his presentation, but I'm quite certain that it was amazing. And this is going to be a little bit of a similar topic. I think him and I are very similarly minded. We are trying to establish a way to get in a more objective assessment of what we do for patients. As neurosurgeons, spine surgeons, what we really do for people is we restore function or we preserve function. At the end of the day, no matter what type of surgeries we're doing, we belong in this wide, big ecosystem of different providers, chiropractors, physical therapists, occupational therapists, pain doctors, neurologists, et cetera. And what we're all really trying to establish is what type of derangement occurred along this patient's health that they're no longer experience healthy function in their life through either pain, neurological dysfunction, or mechanical dysfunction. And unfortunately, the majority of the data that we have that guides our treatments, whether it's an injection, physical therapy, or a large surgical intervention, is based predominantly on patient-reported outcomes, PROMs. You heard Brenton Pennycook talk about the MGOA and the neuric grade. Some of these are physician assigned scores. Some of them are based on patient self-reported assessments of what their function is on a daily basis. And some of these batteries of tests can take, 4, 5, 6 pages to do. And patients have different inter and intra reporter variability that's actually quite remarkable. And people have different understandings of what these questions are. So it's really quite subjective, but yet all of our guidance that we receive from the different guidelines that are out there to treat different pathologies depend on this. And when the physician has a visit with them, it's just a small glimpse on what that patient is doing. So what we've designed, and we already have a functional application for this through an NSA Accelerator grant, we designed an application that pulls data from wearables. We're harnessing society's acceptance of conventional smart technology through their phones and their watches. And we're pulling data off these wearables that's actually quite advanced: accelerometers, gyrometers, different markers of activity, their cadence, things like that. And we're analyzing that with their patient-reported outcomes using a machine learning algorithm that's allowing us to determine a score, a K-score. So there's going to be a pre-intervention K-score of what their function is and a post-intervention K-score that gives us a K-delta of what their function is before and after surgery to know if we're really helping their function. And so this is what we were aimed to do. And these are our collaborators that are helping us achieve this goal. And hope that you guys look favorably upon this. Questions?
So what is exactly the machine learning activity, the deep learning component going to do here? Because it seems like some of these things would actually be kind of measures that are already kind of established from the biometric devices.
The reason we need it is it's not a groundbreaking idea to take wearables and attach them to people and see, are they walking more? Is their heart rate higher or lower as a surrogate of pain? But a lot of those studies have not found a very strong correlation between function and the biometric data. And the reason for this is that I think the data that's been gathered is not granular enough, doesn't have high enough resolution. For example, if you're a 65-year-old American and I do a surgery that Dr. Pennycook was talking about to fix your myelopathy, I'm probably not going to make you go from being sedentary to non-sedentary. So your steps are not going to change. It's not like you're going to go from walking 4,000 steps a day to 10,000 steps a day. But I'm hoping that you might walk a little faster, that you can take more steps without interrupting your activity and things like that. So we're getting more granular in the way we think about the data, rather than looking at these big pictures that it's unlikely that we're going to take a sedentary human to a non-sedentary. For one, and for two is the machine learning algorithms determining which of these variables we're going to assign the most weight to in correlation to the patient-reported outcome. Some of these things may be super important to determine a change in function, and some of them may be less important. And that's what that's doing.
there a way that you can close the loop then in terms of improving the surgery, or how does it?
Well, I think there is an individualization of closing the loop, in that will also allow us to see patients who are dropping off their expected level of function, so that we could potentially intervene faster before their intervention fails, for one. So at an individual perspective, but from a big picture perspective, closing the loop is us figuring out some of the surgeries or non-surgeries that we do, whether they're really working and whether we should continue doing them or whether they're going to get reimbursed.
So are you standardizing the wearable technology as part of this AI training?
We are. So the way that the data is gathered is drastically different between the two big players, iOS and Android. And so there's, the Apple iWatch and basically every other type of wearable out there that's Android compatible. And though the way that data is gathered is apples and oranges. So we can only analyze this data through Apple separately. And then the Android gathered data is going to be analyzed separately, and they cannot be mixed and matched together.
So the data collection is apples and oranges. Is the apple or the orange?
The apple's actually the orange and the Fitbit's the apple. I set you up for that as I saw you eyeing that. Any other questions?
Wonderful. Thank you, Team 10.
Thank you.
And this concludes the presentations for today's pitch event. We do have closing remarks from Dr. Philip Payne.
All right, I have my super technical notes that I wrote down as I was listening to the presenter, so I'm sure they're totally legible. But just for sort of the big picture view, if you think about what we've heard today, it's a really broad range of projects. Projects that touch on topics such as how are we going to improve the delivery of radiation oncology treatment through the use of artificial intelligence, innovative approaches to clinical trial design that will actually accelerate our ability to arrive at insights, especially in difficult to conduct studies. We've seen projects focusing on how we can improve discharge planning and patient outcomes by actually using digital health interventions. Although, just for a moment of levity, I suggested we use a deep fake of the doctors. So therefore, they will all be positive messages and you won't have to wait to schedule them. Even better use of AI. We saw a number of sort of projects focusing on enhancing safety and decreasing costs across a variety of conditions and settings, including in perioperative care, again, all using predictive models. Multiple projects, despite the apples and oranges jokes around the use of wearables and mobile devices to help us understand critical signals, whether that be fluid profiles or blood pressure or functional status in the context of surgical planning. Precision approaches to education and training to improve quality and reduce the cost of laboratory testing, which I thought, again, yet another example of sort of a precision health paradigm. And then finally, a number of projects surrounding neurosurgical planning, again, spanning that spectrum from mobile devices to dynamic image-based metrics. But I think one of the things that all of these projects had in common was this idea of harnessing all of the data that we're generating every day to make smarter, faster, more intelligent decisions and improve quality and safety and decrease costs, which I think, sort of going back to the comments that Tom made at the beginning of the session, really are consistent with our collective mission. So I would commend all of the teams for their work and their creative thinking in terms of bringing these projects forward. And I really look forward to seeing which projects advance. Just to give you a sense of the next steps for this process, much like prior years, we will be aggregating all the scores. They won't be immediately available just this minute, as much as we're all type A personalities and we would like to see our scores, but as soon as we get them aggregated, they will be disseminated. And then teams that are invited for a full application, that'll be due on the 2nd of May. And then we will have a very quick turnaround thanks to our evaluators, and we'll be able to announce the cohort of funded projects by the middle of May on the 16th. So not too long to wait in order to find out what happens next. And then lastly, but most importantly, I have a few thank yous, and I'm sure I'm going to miss somebody, so I'll apologize in advance, but I have really tried hard to collect all the right people. So I want to start by thanking Lindsay, who sort of jumped in, I think as Tom described it, with either head first or both feet, or maybe both at the same time, taking this on just a few weeks into a new position. And this is a non-trivial project in terms of the complexity. Of course, Ali, for leading the charge on the entire effort, and timekeeping today, always a very popular task in any presentation. Everyone loves the timekeeper. I also like to thank Megan for all the great work on just overall project coordination and publicity, as well as our communications and marketing team from the Institute for Informatics. A lot of work has gone into sort of communicating and make everyone aware. I also want to thank our team from EPNIC, Todd and Tori, who worked with us. We're still all learning how to conduct hybrid events, and actually think, other than our muting issues, if that was our biggest issue, that's pretty good for a hybrid event. And overall, I just want to thank all the lab and I2 teams. And then most importantly, I want to thank all of our applicants who brought us their big ideas. Every year, I think this event gets more exciting and we get to learn more about the creative thinking going on at both BJC and WashU. I want to thank all of our judges for their questions, insightful sort of commentary and input for our teams. And I want to thank the audience, both here in person and online, again, for participating and helping us to sort of make this a successful return to sort of a more normal format, or a new normal format for this event. So with that, I'd just like to say thanks. And I think at this point we can conclude the event.